Yeah. And we just like.
I'm great. How about you?
What's up, bro? What's up, bro? All right. Pretty good, pretty good. Can I record a lecture? Is that okay?
Go ahead.
Okay, thanks.
So you don't have to watch how to train.
Posted like 11 announcements.
That's where excuse
Oh my god! Oh.
This is the first one. I know every single day. I think so, right? Hey.
So in 7 minutes I start.
Yeah. The gentleman need to make an announcement.
Yeah. Is it okay?
Oh, that's fine. That's fine. Just let him know that you're on a limited schedule because of that.
Yes. Okay, so just you know that today, because of week of devotion, I need to use just 1.5 hours. So it is not full hour. It is up to 9:30. So either we get 2 minutes for break between the sessions or no break for today.
Let me call to verify it's today.
Okay.
That was always the second week of the quarter.
I don't think it's this week.
Yeah, I'm going to verify just to make sure.
Oh, it's not?
It's normally the second week of the quarter. That's why.
So can you verify that?
Yes, I will verify.
So in that case, it will be good.
Dude, how many announcements? No, I read
It's super old. It was a gift, like, 5 years ago.
Okay, I have the same one, but I don't know what
Really? Yeah.
I think everybody does.
Yeah, I feel like I got it like my senior year or something.
Yeah, really.
Yeah, I know. It's running out of batteries.
Oh, yeah, I just got my battery replaced. They have like this little, there's like this little watch pad on Amazon.
I need to make a 1-year patient clinic on you.
Yeah, I did that last year. It's not that hard. It's just
You guys do it.
you have to
that's all.
print everything out and the modules on there. Yeah, just throw it
Next
in
week.
Next week? So it will be next week.
So they'll get their break.
So we will get your break at 9 o'clock for 10 minutes.
So it's next week.
Yeah, that's what I thought. I'm like, yeah, no, exactly.
We're not normal.
Now, any question from the past? No question from the past. Okay. So you know periodontium and also histology and everything. That's great. Yeah, we do have 5 more minutes. So that's why I'm going to see if there is anything from the past. So I'm waiting for the person who asked about periosteum to show periosteum.
She's here.
Is she here? Did you ask about periosteum? No, somebody else will ask.
I think this is a good picture, though. It explains what you're talking about.
Hmm?
It's a good picture. It explains what you're talking about.
Yeah, exactly. The picture shows. So in other words, bone, you will see bare bone over here. Just on top of that, there is very small, thin area which is called periosteum. And then it is gingival, connective tissue. So,
Got 5 minutes.
yeah, we didn't start yet.
How you doing?
Fine, how about you?
Really good.
Very good, very good.
I was trying to look at.
Now, on this tooth, which is canine, do you see the difference between the shade of the tooth in this part, which is root, to this part, which is crown? It gets yellowish when you get to the root. So when you see in the mouth that suddenly the tooth gets yellowish, you know that you are on the root, and you know that attachment has been lost. Otherwise, you can't see the root. Oh, okay. Yeah. Yeah.
I can never do you like
Yeah, I didn't actually.
it must have
It
been
has like
Maybe HIV.
yeah. So yeah, I was like, we're gonna check my email right now.
We've done one class. We've done one class of the.
But they go out to do the intern.
No, we haven't done that.
Oh, yeah.
We do that in
Not
summer.
yet? Okay, very good. That's why I just wanted to make sure.
But you sound
So, almost 30 seconds.
Your clock is faster than mine.
I'm using that clock. Yeah, it's 8. So I need to start. So periosteum, I brought this slide to show you periosteum, which you will see right over here. It's a very thin layer of connective tissue, loose connective tissue, right on top of the bone, which is called periosteum. And then it is connective tissue of the gingiva. Now, in this, they use partial thickness flap, therefore you can see periosteum. But in full thickness flap, periosteum will be reflected from that. So this is about periosteum. Now, today.
You can put your speaker on because I can't hear you in the back.
Okay, so
So you gotta put it either on your tongue.
somewhere else.
Because I can't hear you in the back.
So I will put it here. How about that?
I'll try.
Right here. Okay, now it's better. Can you hear? Okay. So the topic today is overview of the disease of the periodontium. I will talk about periodontal disease. I will talk about periodontal health, different kind of periodontal disease, about pocket, about progression of pocket, about bone loss, also a progression of bone loss. And finally, I will talk about epidemiology of periodontal disease. So, having said that, let me start. So, pathogenesis, you should know about pathogenesis is, those situations, in other words, the sequence of event which happens in developing a disease, which in this case will be what? Periodontal disease. Now, so I do have lots of slides, but they are short. In other words, and sometimes it is repeating, so that you remember what I am talking about. Now, periodontal disease, first of all, it is a bacterial infection. So you tell the patient that you do have infection when you do see bleeding and probing and the rest. Then there are two types of periodontal disease. One is gingivitis, according to the new classification. We just have two types of periodontal disease. Gingivitis, periodontitis. In the past, we had chronic periodontitis. We did have severe and so forth. Right now, we are dealing with staging and grading system, according to the new classification 2017, which I will go over that when it comes the time. Now, gingivitis basically is infection of gingiva. It confines to the gingiva. Periodontitis is infection of the periodontium, which is what? Which is gingiva, bone, PDL, and what else? Cementum, which they don't mention, but cementum also we get soft cementum because of periodontal disease. And you do root planning to remove those soft cementum. So that's about periodontitis. Now, just remember that when we talk about periodontal disease, it is not the same as periodontitis. Periodontitis is a form of periodontal disease, but periodontal disease can be gingivitis, can be periodontitis. So this is the difference. Difference between periodontal disease and periodontitis. In other words, periodontitis is a kind of periodontal disease, but periodontal disease is not always periodontitis. Now, next item, about basic states of periodontium. We do have three basic states. One is health, the other one is gingivitis, and the other one is periodontitis. So we see that how nicely they categorize periodontium into healthy, into gingivitis, or periodontitis. Just these three categories. Now, in health, what you do see, you will see the gingiva looks pink, looks pink color. Also, you see interdental gingiva and so forth. There is no puffiness in disease. You see the difference in gingivitis. You see the difference. In other words, the color get to red, then the consistency get some. You see, it is puffy, and so there is a difference. Just by looking at that, you know that something happened. It is not gingival health. It is gingivitis. So gingivitis is infection of what? Of just soft tissue. Now, in other words, in periodontitis, you see the first one, it shows that this is what? Sulcular epithelium. Then it is what? Junctional epithelium. You remember that. Now, in health, when you probe, it will come up to here, which is right up to junctional epithelium, but it passed a little bit, about 1/3 of junctional epithelium. It may penetrate that area. Now, in gingivitis, what happens when you insert the probe? It will go more. It will go about 2/3 of junctional epithelium. It will go down. Now, in periodontitis, what happens? The whole junctional epithelium, it will traverse the whole junctional epithelium, and it ends somewhere here. And you know that anyhow, in periodontitis, junctional epithelium is on what? On root. In gingivitis and in health, junctional epithelium is on crown. It is never on root in health or in gingivitis. Only in periodontitis, you see junctional epithelium, which is from here down, it is en route. Why? Because the bone resorb, I mean these fibers which are called what? Supragingival fiber, destruction happened and then they formed more apically. So this slide shows what? This one. When you see this slide, if you see this slide, you know that periodontitis, this is a periodontitis. Now, periodontium in health, you will see histologic, clinical. Clinical picture of health is what? When you see it, it is pink, it is firm, and you can't get bleeding when you probe. Now, when you get probing, when you do probing, and you get bleeding, why you get bleeding? Because in general, whenever you get bleeding in any part of the body, if there is a break in epithelium, then you will get bleeding. It's from connective tissue. It's the same thing here. In other words, there is a break in epithelium. Which epithelium? Sulcular epithelium. Because of what? Because of noxious agent from biofilm, dental plaque. Therefore, when you probe, it gets bleed. Why? Because there is ulceration over there. So you will see no bleeding in health. Now, histologically, what you see, junctional epithelium is coronal to CEJ. You won't see junctional epithelium apical to CEJ in health. Now, then, supragingival fibers, they are intact. Alveolar bone also is intact. So these are intact. Nothing happened to them. And periodontal ligament also intact. So this is health. Now, when, okay, so now you see, in this picture it shows junctional epithelium, it is all on enamel, nothing on crown. Then you will see also, you won't see those rete peg, what was it called? In the last lecture I talked about that, which usually you will see, on this side, you see this, in other words, it is not straight, but here you see straight, because there is no disease. Now, when there is disease, you will see it will not be straight like that. I'm talking about junctional epithelium. Okay? So, in health, you will see junctional epithelium just on crown. And the rest also, you will see no bone loss. You will see gingival connective tissue, no loss of gingival connective tissue. So this is in health, but in gingivitis it's different. Now, in disease, periodontium in disease. Periodontium, we know that gingiva is part of periodontium. Now, gingivitis is one infectious disease of periodontium. Now, then gingivitis, characteristic, color, contour, consistency changes from normal, from health. So you will see these things. It doesn't mean that you should see all changes on the same papilla or marginal gingiva, but you will see these changes in gingivitis. Now, usually after 4 to 14 days, now pay attention to this part. After plaque accumulation, where? In the gingival sulcus. This is important. Okay? So in other words, not just at the margin or on the crown. In the gingival sulcus, after 4 to 14 days, accumulation of plaque, no disturbance by anybody, then you can get what? Gingivitis. Does it mean that everybody, if they don't disturb, the plaque, after 14 days they will get gingivitis? No, because there are other factors which cause disease. But basically it's like that. And the key point is what? It is within the sulcus which you get gingivitis. So, now next one. Gingivitis, we call it either acute gingivitis or chronic gingivitis. Now, acute, it has short term, and then it will be resolved, or by whatever. Now, characterized by what? Fluid in gingival connective tissue. You remember we talked about what? Clavicular fluid. So you will see clavicular fluid in connective tissue, which seeps up to where? To the sulcus. Or in this case, it will be what? Pocket. Now, what's the difference between pocket and sulcus? Sulcus, ulcerated sulcus is pocket. In other words, when you can see bleeding on probing, then you know that you can't call it sulcus. It will be pocket. Now, then, another characteristic of gingivitis is what? Tissue looks swollen, boggy. Now, next one. Now, acute chronic gingivitis lasts, it is what? It's of long duration. In other words, it lasts for months or years. Now, new collagen fibers form, and you will see fibrotic tissue. In fibrotic tissue, you will see in chronic gingivitis, not in acute, because in acute, there is no time for a new collagen fiber formation. So basically, you know that when infection happens and it gets chronic, you will get fibrotic tissue. You wonder why how pocket is so deep, but the tissue is fibrotic because of the body reaction to form more collagen fiber in that area. Now, this one shows gingivitis. You see the difference in appearance of epithelial, junctional epithelial and sulcular epithelium. You see epithelial ridges. On the previous slides, which was healthy, you couldn't see. So this is one. Now, next one is what? You can penetrate more into junctional epithelium in gingivitis, about 2/3 or something like that. Then what else you see? Swollen tissue. Tissue is boggy. Junctional epithelium is still on crown. It's the same as in gingival health. So now, gingival fiber, you see gingival fiber, there is destruction of gingival fiber because of what? Gingivitis. So you remember that. Now, but alveolar crest and periodontal ligament, they are intact. So you see the difference between healthy gingiva and gingivitis. Now, next one, progression of gingivitis. Now, gingivitis, remember, gingivitis is reversible. Periodontitis is irreversible. Now, gingivitis may persist for years and without proceeding to periodontitis. In the past, they thought that gingivitis finally will end into periodontitis, but that's not the case. They proved that that's not the case. So remember, gingivitis can be for years without proceeding to periodontitis. Now, so we talked about gingival health, we talked about gingivitis, now periodontitis. Periodontitis characteristic, apical migration of junctional epithelium. This is very important. Up to now, there was no migration of junctional epithelium. In health, it was on crown, in gingivitis, on crown, in periodontitis, apical migration of junctional epithelium. Now, loss of connective tissue attachment, loss of alveolar bone, and then we know that the tissue damage is irreversible. So this is the difference between gingivitis and periodontitis is irreversible tissue damage. in periodontitis. Now, in this sketch, it shows periodontal pocket from histologic point of view, which is junctional epithelium on cementum. Now, do you need to go over that? Because I talked about that. But it is good to go again so that you remember what's going on. Now, junctional epithelium on cementum in the previous part, which was gingivitis, junctional epithelium was on crown. Now, supragingival fiber destruction, alveolar bone destruction, periodontal ligament destruction. But they didn't show what? Cementum destruction. What happens to cementum? Because of the plaque and byproduct and so forth, you get necrotic because it also affects, but it is not destructed. So they didn't put it down here. Now, about clinically, you will see in periodontitis, either you see pink or purplish. Okay? You see it is pink. You think that this is normal. But no, there is disease. Now, swollen or fibrotic, you can get fibrosis at swollen. And also bleeding. Bleeding is very important. And nowadays, what we do about to decide which tooth is periodontitis, we check the depth. If it is 4 millimeter and more and bleeding on probing, then that tooth has periodontitis. In the past, it was different. We went for attachment loss on every tooth, and then we decided what's going on. But nowadays, it is completely different. Now, next one. Next one, again, gingivitis, which is reversible. Then clinical picture, we talked about that, so I'm not going over that again. Now, on this picture, it shows what? Periodontitis. Why? Because you see, junctional epithelium is on what? On root. You see, it is showing this part. This part is crown. From here on is root, and junctional epithelium migrated on root. Yes?
Do you have these things like this on the test as far as like images, and you have to describe what it is, or pick through A through D what it is? Like, do you have a picture on your test?
Oh, so in other words, you don't want me to go both of them?
She's asking.
Oh, I do have both of them. In other words, written, and actually this is a study guide, you can use it. Because the whole thing, the whole lecture is a study guide. You will see it is in detail. I have everything on slide. But something, it might not be on slide, therefore it is good to also check the book. Yes?
So, you said the whole lecture is a study guide, and last time you said you would give us a study guide.
Yeah, but I didn't know exactly what study guides means. And thanks to Debbie, she showed me what's the study guide. And she showed me that in case of study guides, they put just a few slides, and then it is study guide. But I have everything on here. Now you got my point?
Yeah, because
But if you want again these things to be printed, that I need to talk to the department.
oh no, not printed. It was more because it's so much information. A more condensed study.
Oh, so you want something, in other words, you want me to put something at the end. Yeah? So in other words, just the topic, I can do that for the rest of the lecture.
Like what you want us to know for the test, like that.
Okay, for the test, you need to know the book. Because I go to the book.
We're just giggling.
And actually, I am giving you every lecture a quiz because of that. So that you get accustomed to what's going on and what you will get. You get my point?
Yes.
In other words, you will be ready for the exam every minute.
So, like, you can give us a picture like this and ask if this is periodontitis or...
Up to now, I didn't, but I might do that. Yeah. because whatever I present or the book has, I might use it. But up to now, you will see, I didn't use it. Yes. And I'm glad that you are bringing this point. Yes.
Are your tests multiple choice like the quizzes, or are they also?
Yeah, that's the point which I'm bringing. Because I'm giving you quiz, and they are multiple choice.
Yeah.
Most probably, all of them will be multiple choice.
Okay.
I can use also, there are different things, true and false. Then there is matching, which you need to match, and so forth. So if most of you likes those things, I will go over that. But otherwise, I'm giving you the samples. Okay? And just go over those samples, and you might get some of those questions in your final or in midterm. So I want you to be familiar, not to be surprised what's going on. Because some of them you need to think slightly. Then some of them more to think. Some of them no thinking. Just you know that. That's it. But that's the nature of multiple choice. And I'm glad that you bring it up. Now, any suggestion, please let me know.
Study guide.
Okay?
Study guide.
Study guide.
Yeah, suggestions.
Study guide, I need to see with Debbie Johnson if they said, or otherwise I can put at the end of the lecture just a brief things about the whole thing, which I talked at the beginning, which I'm talking about this subject. Okay? Now, anything else?
No, let's move on.
Okay. So this is what? This slide shows periodontitis. Why it shows periodontitis? Because it doesn't show gingivitis. Huh? Okay. So very simple. Now, microscopic periodontitis. So you see junctional epithelium located below normal position. Where was normal position of junctional epithelium? It was above CEJ. It was on the crown. Now you see below that. Below that, where it will be? It will be on the root. Then coronal, most part of junctional epithelium is what? Detached from tooth. Then you will see ridges into connective tissue from junctional epithelium, which I showed you. Then junctional epithelium, in other words, circular epithelium of pocket thickens. Circular epithelium also thickens, and it shows also what? Epithelial ridges. Now, in some area, now here the last part is important. Small circular epithelium ulceration. So this is about ulceration of circular epithelium. Exposed, inflamed, underlying connective tissue. And that's why you get what? Bleeding on probing. Because of ulceration of circular epithelium. So let's go. So this is about what? About periodontitis. Now, in gingivitis, do you have also ulceration of circular epithelium? Yes, you should have. Otherwise, why you get bleeding? Bleeding never happens if epithelium is intact anywhere on the body, on any part of the body. So, next, it is continuing. Now, collagen destruction happens in periodontitis. You know that epithelium grows over root surface. So in other words, in gingivitis, epithelium is not over root surface. In this part, in periodontitis, it goes over root surface. Now, supragingival fiber, we know that destruction happens, and transseptal fiber bundle continue to regenerate. Where is the location of transseptal fiber bundle? You remember that? If you don't remember, then transseptal remembers that you don't remember. Exactly. Very good. So transseptal fiber are between adjacent tooth, and it shows that it regenerates. In other words, you get destruction of fiber, and then regeneration of fiber. So always you will have transeptal fiber between the teeth. Never without that. Okay? Now, next one. Next one, again, is a continuation about alveolar bone, which is destroyed, resulting in mobility, destruction of periodontal ligament, permanently will be destruct, will be go away, periodontal ligament, that part which is affected. May get involved, may get involved. So next one, let's go to the next one. Okay, so this one, it shows intact transeptal fiber. You see, right now, junctional epithelium is en route. This is one tooth, this is another tooth. Now, cementum up to here, then junctional epithelium en route, but transeptal fiber is intact. Why intact? Because after destruction, regeneration happened. So remember, transeptal fiber always is there. Now, section 2 is pathogenesis of bone destruction. So we go changes in alveolar bone, which happens in periodontitis. Now, reaction to injury by disease. Okay, so first it talks about inflammation. Inflammation is a reaction of what? Reaction of body to injury, or to what? Or to infection. Then you get inflammation. Inflammatory process in periodontal disease result in what? In tissue destruction. Tissue destruction, which will be what? Destruction of bone, destruction of gingiva, destruction of periodontal ligament. So that's because of what? Inflammatory process, which we get tissue destruction, finally. Now, alveolar bone in health, it is 2 millimeter, usually below cemento-enamel junction. So in other words, it is 2 millimeter below the crown, alveolar crest or crest of the alveolar bone. This is in health. Now, in gingivitis, where alveolar bone crest is, where is that? Again, the same thing, 2 millimeter below crest, below CEJ. You will see alveolar crest or crest of the alveolar bone. So that's about the location of alveolar bone in health. Now, in periodontitis, because of bone resorption, then where the alveolar bone crest is located, in reference to CJ. It is located more apically. In other words, it is no longer 2 millimeter. 2 millimeter is an average. Now, it in different people can be a little bit less or more, but basically, according to the study they did, they come to the conclusion that it should be 2 millimeter down. Now, if it is not 2 millimeter down, then what will happen? Then it's not. Anyhow, so in periodontitis, location of CJ location of crest of the alveolar bone. Now, remember, alveolar bone is this part which which the tooth is housing there. Now, crest of the alveolar bone is just this part. In other words, the most coronal part is crest of the alveolar bone. So, in periodontitis is lower. Now, alveolar bone loss in periodontitis happen, and eventually it can cause what? Tooth loss. Why tooth loss? Because of mobility, because the patient cannot function, and so forth. So it ends to tooth loss. It can end to tooth loss. It doesn't mean that every periodontitis will be. Now, so it was about pathogenesis of periodontal disease. pattern of bone loss in periodontitis. This is another subject. Now, we do have two patterns of bone loss in periodontitis. Either you get horizontal bone loss or you get vertical bone loss. Now, something just to consider. Now, can you get horizontal bone loss without vertically losing bone?
Yes.
No, you can't. No, but they don't mention it. In the book, they don't mention it.
I see the book is wrong.
In other words, you need to get vertically bone loss to get horizontal bone loss.
Okay.
You get my point? It is not here, it is not in the book, and I'm just throwing so that you think about what you see.
So vertical bone loss causes horizontal bone loss.
So in other words, vertical, okay, according to the definition, how they define vertical bone loss versus horizontal bone loss.
So
They use two adjacent CJ. Two adjacent CJ. If the crest of the bone is parallel to that imaginary line, they call it horizontal bone loss.
okay.
If the crest of the bone is not parallel to the line which connect two adjacent CJ, they call it vertical bone loss. Okay? But, so according to the definition, is just like that. But if you think about vertically and horizontally, then you remember that, okay, if you want to get horizontal bone loss or any kind of bone loss, it is a vertical component to that.
Okay.
You get my point?
Yes.
That's it. But according to the definition, this is horizontal bone loss, this is vertical bone loss, and I bring these up so that you get, you have a broader view what's going on. Which the book, either they don't put it or it is not intended to put. So, about horizontal bone loss, vertical bone loss, we talked about that. Now, so it is self-explanatory about horizontal bone loss and vertical bone loss. Marginal alveolar crest remain mostly perpendicular to the long axis of the tooth. This is about horizontal bone loss. Now, about horizontal bone loss in here, it shows horizontal bone loss. In other words, when you connect this CJ also, the crest of the alveolar bone, which is, you see, it is slightly slanted. But when you connect two adjacent CJ, it is again slightly slanted. Therefore, it is horizontal bone loss, according to the definition. So you might have more slanting, but when you connect two adjacent CJ, that imaginary line is parallel to the crest of the bone, you do have horizontal bone loss. Now, then vertical pattern of bone loss. So we know that horizontal bone loss, you see mostly horizontal bone loss when you see x-rays of the patients which have periodontitis. Now, in some cases, in few cases, in less common, it is less common, vertical bone loss, vertical pattern of bone loss. Now, result in what? In uneven reduction in bone height between two adjacent tooth. And then more rapid progression of bone loss next to the root surface. So in other words, we know that on one root surface, there should be more rapid bone loss in order to get what? Vertical bone loss. Otherwise, if it is the same, with the same speed of bone loss on the both tooth, it will be horizontal bone loss. Now, also it talks about a trench-like area of missing bone alongside the root. You will see now in this picture they showed bone loss and a trench-like area between the two roots. So, in other words, when you describe a vertical bone loss, you know that on mesial side of this tooth, which can be which tooth? Either 29 or tooth number 20. Now, which one is that? Can you say from the X-ray whether this is number 30 or this is number 19? Can you say or not?
It's 29.
This is 29. How can you prove that this is 29?
Because it's right next to the molar.
Yeah, it's next to one molar, but 19 is also next to what? Number 20. So in this picture, they didn't talk about the tooth. But in general, can you distinguish? Or you see, I mean, the FMX, and then you know what's going on. But just think about that. I mean, how is that?
That's the only one that it can be there.
That's the only,
If
okay.
it's 19, it would be
Would be what?
turn around.
Yeah, I know, but how can you prove that this is not 19? Anyhow, I need to get his advice because I can't prove the other way.
It's opposite, so it looks like it's this side, but it's this side. When you mount it, it would go.
So this is number 30, yeah? 30 and 29? Okay, so 30, 29. Good. Okay. So the end of discussion. Very good. So next one. Pathway of inflammation into the bone. So pathway of inflammation into the bone, we can have two different pathways. One which cause horizontal bone loss, the other one will cause what? Vertical bone loss. Now, pathway, usually horizontal pathway is what? Is from gingiva into the gingival connective tissue, then into the alveolar bone, and then into periodontal ligament. This is horizontal, this causes a horizontal bone loss. So this is one pathway. Now the other pathway, so you see, it is from connective tissue, gingival connective tissue. You see, it originates here, then it comes into this area on the gingiva, then it proceeds to the bone, to the crest of the alveolar bone, and then it proceeds to what? Periodontal ligament. So this is one pathway. Now, which causes horizontal bone loss. Now, next one is vertical bone loss. In vertical bone loss, what happens? Again, inflammation, it comes from here, circular epithelium, then it will come into connective tissue, gingival connective tissue, and then instead of going into the bone, it will go into periodontal ligament, and then into the bone. Therefore, you get what? Vertical bone loss. Okay? Now, they said that because the crest of periodontal ligament fibers are weakened, when the crest of the, so the question is that when the crest of the periodontal fiber will be weakened and no longer act as an effective barrier to inflammation, then this happens. So how they know that the crest of the periodontal ligament weakened? So you should just ask why.
Why?
I don't know. That's why I'm asking you. So how can they prove that? They prove it because what? Because inflammation went into a periodontal ligament. And how they came to this concept, it goes back to, I mean, some histologic study which somebody, I think in Japan, they did, and they saw inflammation into PDL. Then they came to this conclusion. So, but according to them, when the crest of the what? Periodontal fiber is weakened, then this will happen. Now, when you go to occlusal trauma, then they say that in the presence of occlusal trauma, causes, instead of going straight into the bone, into periodontal ligament, but they didn't mention here. So that's another theory which they use, which Glickman called that. So anyhow, these are the things which you need, if you want to think, you don't have anything to think, then you can think about that. Yeah, okay. If you have enough things to think, then forget it. Leave it to somebody else. At least know what's going on. That's it. Now, bone defect in periodontitis. So we talked about pocketing, about spread of inflammation, about basically inflammatory process which cause what? Which cause tissue damage. Periodontitis is because of inflammatory process. So remember these things. Now, bone defect in periodontitis, we do have infrabony defects, which is called on the basis of the number of osseous wall which is remaining. They call, so in other words, according to, periodontitis defects, bone defects, we do have infrabony defect, means that the defect is below the bone crest, below crest of the alveolar bone. Now, one wall infrabony defect, it shows one wall because of, the normal inflammatory process, just one wall is remaining here, which is on which side of this tooth? It is on distal side of this canine. So it is called one wall defect. And it is infrabony defect. Why? Because this part from here to here, these are bone, it is defect. It is not normal. So this is one wall defect. It has just one wall remaining, which they call it also hemiseptum. Now, two wall intrabony defect. They use infrabony there. Now here, the book is using intrabony. Now, two wall is remaining. One wall is distal side, distal wall. The other wall is what? Is a lingual wall. So you don't have a facial wall. So in other words, right now we have how many wall missing and how many wall we have? We have one wall missing, which is mesial wall, and we do have two wall remaining, which is distal wall and lingual wall. So this is two wall intrabony defect. Now one can ask why they used, in that case, infra. Now here they use intra. Now if you don't ask, that's okay. If you ask again, is okay. What's your question?
So, isn't that the one that's gone?
Oh, no. You see, when we call about two wall intrabony defect, it means that we see intrabony defect which has two wall, two remaining wall. One wall is here, which is adjacent to that tooth. The other one is away, which is toward lingual side.
So mesial is missing.
Mesial is missing. So we are talking about the remaining walls. When we call one wall defect, it means that one wall has remained. When we talk about three wall, I don't know whether they put three wall or not. No, they didn't put three wall because it is difficult to show. Then you see three wall remaining. Yes.
So on the previous slide where it says one wall, you said the distal side is missing or the mesial side? Wall.
Oh, one wall, the wall which you see, which you saw distal wall. You saw distal, on distal side of the tooth, you see bone. Therefore, it is one wall, and that wall is present. So in other words, missing walls, it was two wall missing. One was buccal, the other one was lingual.
Can we go back to the first picture and you can point it?
The first picture now, let me see how can I go back. First picture, which one was that? Let's see. So this one, it goes all the way. So if it is 9 o'clock, you can get...
Our technician will...
Oh, technician, okay. So let me go, then technician will show me. Good to have technician.
Yeah.
Very good. Very
It's
good.
education for free.
For free, yeah. Complimentary, yeah. Okay, so
There we go.
go to, okay. So this is two. Okay, good to have the technician right, ready, and free of charge. Man, that's better. Okay. Very good, very good. Okay, so is the problem solved? Young man or young woman? Yes.
So over here it shows one wall.
Yeah, one wall. This is one wall intrabony defect. This is just this wall.
Okay.
You see bone.
Okay, one wall is defective. So that means there's three remaining walls?
So in other words, you won't see anything on lingual side. You won't see anything on buccal side.
Oh, I see.
You see what I mean? And the fourth wall is what? Is PDN, which is destroyed because of inflammatory process.
I don't know, I just feel like the only distal side is.
You see,
affected.
distal side is bone, yeah?
Yeah.
That's one wall intrabony defect. Because around that tooth, you won't see, you see here, you see bone, here you see bone, so there is no defect on this tooth. But over canine, you do have defect.
Just a distal defect.
So it is the distal wall, yeah, it is one wall intrabony defect.
So then how many walls do we have remaining? Is it the whole three sides?
So remaining on other side, yeah, you do have, in other words, mesial side, there is no defect. Just distal side, you do have defect. And that's because of what? Because of periodontitis, because of inflammatory process of periodontitis. Okay? Now, any question? Yes?
So is one wall worse than two wall?
Okay, two wall, when you see two wall, then here you see two wall. Why you see two wall?
Better or worse than the first?
Oh, no, this is, two wall is better.
Two walls better.
Yeah, exactly.
One
Three wall is the best.
Because one wall, you only have one wall left.
You have just one wall, yeah. Exactly. Here you do have two wall, it's better.
Okay.
Now, if you have three wall, that's the best.
Yes.
Okay? Which right here they didn't show three wall. Now, next thing they showed is what? Interproximal osseous crater. Now, interproximal osseous crater, you will have two wall, it is two wall defect. In other words, you will see the wall which is what? Facial, and the wall which is lingual. So that is interproximal osseous defect.
So you said something about two wall for this?
Yeah, this is, in other words, when they talk about interproximal osseous crater, when they talk about crater in periodontic, it means that it is two wall defect.
Okay.
Okay? So, crater, okay. Crater may be the last part, the more apical part may be three wall, but basically it is two wall. When we talk about interproximal osseous crater, crater it is two wall, especially on what? On coronal area. So this is about osseous defect. Now, contour of interdental bone. You will see normal contour of interdental bone. This is on premolar or molar. Now, is this premolar or is this molar?
Molar.
This is molar. So you will see the contour. It is what? It is convex. Now, in osseous crater, you see this is two wall. One wall here, one wall here. Osseous crater, you will see the reverse. In other words, instead of convex, it is concave. Now, this is what? Cross section, sagittal view, what they call it. I mean, from anatomy point of view.
Coronal plane.
So it is sagittal. Sagittal, okay. So this is about contour of interdental bone. Now, then furcation involvement. Furcation involvement happens when periodontitis invades furca. In other words, comes to the area of furcation. Now, causes what? Causes alveolar bone loss, in the furcation area. So about furcation, I think in the next session I will talk about different type of furcation involvement. But next session I think I do have more slides, but I do have less time. So I need to know how to go about that. And just I need to remember to give you a short overview at the end so that it compensates for study guide.
Thank you.
The whole thing, then it will compensate. Okay? Or at the beginning, whichever. Which one is better, at the beginning or at the end? At the end, okay. Yeah. So it goes. So this is about furcation involvement. So furcation involvement we do have in multi-rooted tooth, and that's because of what? Because of periodontitis when it reaches there. And now you know that furcation involvement, furcated tooth, we do have molars are furcated. Also we know that first upper premolar is furcated. Now first upper premolar has furcation mesial and distal. Usually it is more down. I think it was 6 millimeter down CJ, so it will get involved late during periodontitis. But some furca, like buccal furca or mandibular molar, they get sooner involvement, and you can check that. Now furcation, we do have, I don't know whether it was over here. So we will count that. Now this is what? Type, we do have type 1, 2, 3, 4. 4 is when you can see like that. I mean the entrance and so forth. And on the X-ray you will see what? Radiolucency in furcation area. So it doesn't mean that you should see radiolucency in furcation area in order to detect furcation. You might not see on radiograph, but clinically you will find it. So that's more prevalent. And we know that on upper arch, we do have mesial, distal, and buccal furcation on molars, which you use a neighbor probe to detect it. So that's about furcation now. Then a periodontal pocket. I do have still, I think, about 6 minutes to the break. So let's go. Periodontal pocket. Now, periodontal pocket is, we do have either gingival pocket or periodontal pocket. Now, gingival pocket, depending on gingival sulcus, as a result of inflammation. So in other words, there should be inflammation, and then you will get what? Depending how you get, depending. In other words, in gingivitis, we know that there is no apical migration of junctional epithelium. So from apical side, we don't get, depending, the coronal portion of junctional epithelium detaches. Therefore, you get what? Deepening of the pocket, and also ulcerated. Swelling of the gingiva also contribute to what? Increased probing depth in gingivitis. So in gingivitis, because of two things. One is what? Detachment of coronal part of junctional epithelium. And the other one, because of swelling of the gingival tissue. You will get height, in other words, the pocket will be higher. You will get a higher number. Not 2 millimeter, 3 millimeter, 4 millimeter, 5 millimeter, and so forth. So that's the reason. And that's gingival pocket. Why it is gingival pocket? Because junctional epithelium didn't migrate en route. Therefore, it is gingival pocket. Now, healthy gingival sulcus, here it shows healthy gingival sulcus. Junctional epithelium along its entire length is on the enamel. Then gingival pocket, coronal portion of junctional epithelium detaches from the tooth and cause what? Increase in probing depth. So that's one reason. Now, next one. Again, swelling. In this slide, it shows swelling. It causes also heightening of gingival pocket. So because of those two factors, we get what? More pocket depth. So gingival pocket characteristic. So yeah, this is very important. No apical migration of junctional epithelium. This is very important. In gingival pocket, no apical migration. Now, junctional epithelium remain coronal to CJ. It is not going below CJ. In what? In gingival pocket. Now also it is called pseudo pocket. Why it is pseudo pocket? Because there is no destruction of PDL fibers or alveolar bone. Now in true pocket, we do have destruction of what? Of alveolar bone and PDL. But in pseudo pocket, we don't have. Therefore, when you hear pseudo pocket, it's the same as gingival pocket, and it is when there is no alveolar bone loss or periodontal loss, periodontal fiber loss. Now, periodontal pocket. We talked about gingival pocket. Now we talk about periodontal pocket. It is pathologic deepening of gingival sulcus as a result of, first, apical migration of junctional epithelium. This is very important. Apical migration of junctional epithelium, you will see in periodontal pocket. Now, destruction of periodontal ligament fibers. This is another item we have. And also, we do have destruction of alveolar bone. So, because of those destruction, we get what? Periodontal pocket. Now, then they categorize into supra-bony and infra-bony pocket. Now, you remember about, the defect. We did have intra-bony defect. Now, here we do have supra-bony and infra-bony pocket. So they categorize pocket into supra-bony, infra-bony pocket. Now, in order to know that if it is supra-bony or infra-bony, you need to have what? To go back to the X-ray and then decide. You can't just say, okay, this is infra-bony or supra-bony. Now, okay, so in supra-bony pocket, when there is horizontal bone loss, then you know that you are dealing with supra-bony pocket. So it is easy. Now, junctional epithelium is located coronal to the crest of the alveolar bone. So in other words, it has migrated on root surface, but it is coronal to the crest of the alveolar bone. This is one character of supra-bony pocket. Now I do have 1 more minute. Infra-bony pocket, when there is vertical bone loss. When you see vertical bone loss, then you know that you are dealing with the infra-bony pocket. Now, junctional epithelium is located apical to the crest of the alveolar bone. Now, in supragingival, supra-bony pocket, junctional epithelium was located coronal to the crest of the alveolar bone. In this, which is what? Infra-bony pocket, it is located apical to alveolar bone. Now, base of the pocket is located within the cratered out area of bone. Okay, because it is cratered out of the bone. So this is about supra-bony, infra-bony. Now, I think I have... No, time is up. So you have 10 minutes break. So use it to the best you can use. And I will start at 9:10.
Yeah, that was routine.
But you would say like
So the teeth is on the distal side, but then this would make the mesial wall. Is that amazing? Okay.
so. Landlines everywhere.
If you think of it, because it's hard to see because that's a 2D picture, but if you think of it, there's 3 dimensions.
I showed
So
now we only question.
So basically, there's 4 ways of break or 4 ways. So don't confuse the mesial side and mesial wall. Here's the mesial side and here's each side. So don't confuse the distal side, both mesial. Seminar is straightforward. Much, yeah. That one and so this picture is the one the mesial side. Yeah. Which is the distal still there. Yeah. But the distal the distal side of the distal wall of the canine is there. Okay, so the mesial, the defect is on the distal of the canine.
So how is that?
Because I think you're confusing the term wall with side. She just put a little. Here's the side of the canine. It's just the side. This is the wall. Wall. All the other walls from the distal side aren't.
Intermission time?
Intermission? Yeah,
How are things
exactly.
going?
Timmy is going good.
Very good.
Good. Yeah, unfortunately, the participants are
Very good.
asking questions.
You're not reading the slides, right? Good. That's wonderful.
So we want, I told them at the end of the lecture I will put, so I need to add those things. A brief overview of the whole lecture.
Okay.
Because they are asking for study guides and things like that. So
The first one,
only thing
first one was a study guide. That first lecture was a study guide. This one I think you probably could just summarize. It might be good.
summarize at the end so that I will for the next, if they get something wrong.
Okay. Don't give them too much, because like I said, it's helping you to make sure they have to listen and pay attention and take notes.
Yeah.
Because I'm watching a lot of them that still aren't. And the ones in the back, I'm sitting with them, and they're taking notes and they're paying attention. I think it's great. But the ones there's some in the middle that are just off in their own la la
I told them
land.
that I gave every session quiz so that they get accustomed to what I did and find out.
So sorry, I'm a mess.
And they need to think about it. It is not just I did this one or that one. So I told them.
That's good.
So I hope that they listen.
I hope they're paying attention and they're taking notes and they're listening to what you're saying.
Yeah.
That's very good.
Good?
Because that first Monday morning class, everybody's tired and long weekend, try to get them awake. So you give them 10 minutes, you give them 5
10
minutes?
minutes. Yeah, 10 minutes. I use that clock for about 3 more minutes and I stop.
Okay, very good. All right, very good. All right, I'll be back towards the end of your class.
Thank you.
Very good.
Okay.
You'll be fine. 4 hours? No. Oh, pregnant.
So I was reading the description in the book, and it's saying that the one wall, and it's saying looking from the canine, distally toward the premolar, and it's only one wall of bone remains, and that is on the mesial surface of the premolar.
Okay, yeah. Mesial surface of premolar.
So this is the mesial?
Okay, so distal, it is distal of these two, which you have lost. Okay, so if they use that one, yeah, it is the mesial of these two, which is the remaining wall, which belongs to this.
So this right here.
Yeah. No, you see, remaining one is this one, which is on distal or canine or mesial or premolar. Now, they use mesial, that is on mesial surface of the premolar. Yeah, it is on mesial surface of the premolar, which you will see. Very good.
So where is the defect? Where's the defect?
Defect is right here, on distal side of canine. That's, in other words, this space is the defect.
Yeah.
Yeah. And
So where the defect is that where you say that's what's not there, that it's not remaining?
it is not remaining, yeah, it is not remaining, but remaining is right on distal side of this tooth, or mesial of this tooth. The tooth, the book use mesial, so I use mesial. So
this is,
no.
so this is the mesial of the canine.
No, this is the mesial.
This is the distal of the canine.
Yeah, you have a
So
defect
you're
is
saying that the defect
is on the defect is on distal of canine.
yeah.
Yeah. But you can say that the wall is located on mesial of
Oh, but can you also say that can you also say that the mesial of the
no, mesial,
canine
there
has
is no mesial of canine, you have no defect.
Oh, so you're only looking at
What is over here, which is located on distal of canine or mesial of canine.
Okay.
Okay?
Okay. So then for this,
For this one, it's called two-wall intravenous defect with facial plate or bone missing. Yeah, facial is missing. The rest you do have.
okay, two walls of the bone surrounding
Lingual.
so lingual
Yeah.
and
Or
bone
on the
on the
mesial
mesial
surface.
surface.
This is remaining, yeah. Mesial surface, you do have bone of these two.
But here, facial and distal
Yes,
are not
exactly.
there.
Are not there. Okay,
Okay.
very good. Paid attention. Very good. Okay, so 10 minutes. Actually, it is 10, a little bit more than 10 minutes, so it is up. I need to proceed. Now we are talking about disease sites. For the next lecture, which you have less time, I think I do have more slides, so it is to your benefit to check that before, because that is very important. It is about classification of periodontal disease. In the next, I will put something at the end so that you know basically what we talked about that. But it is better to check that lecture before, because it is an extensive lecture. It comprises of, I think, 4 chapters in one presentation, which comes under the heading of classification of periodontal disease. Now, if the next lecture is that one, that is a good, I mean, important lecture, and it has different components from different chapters. So just make sure that you check that before coming to the class. Now, disease site. Now, what is the definition of disease site? Attachment loss. Attachment loss. So let me see. Attachment loss. Attachment loss is what? Destruction of the fibers and alveolar bone that support the tooth. That is called attachment loss. So we talked about attachment loss, we talk about what? Bone, and also about PDL, which has been lost. So that's attachment loss. And then the base of the pocket may exhibit a very, okay, that's about the pocket. The base is irregular. It can be in different shape. You can see on these slides, the base is not just straight. It goes like that, then goes here. When you do probing, now are you doing probing right now in the clinic?
Yes.
So you will see that you need to walk and you see what happens. It will go down, it will come up. That's why. I mean, in this slide, it shows the base of the pocket can be in different shape. And that's why you will see what happened with the probe. It depends why you see like that, because of the pattern, irregular pattern of bone loss. In other words, the bone will not loss just evenly. Now, a disease site is what? Is an area of tissue destruction. That's the disease site. Now, disease site can be active, can be not active, inactive. Okay? Disease site may be just on one area of a tooth or on the whole tooth area in one location in the mouth or in the whole mouth. So in other words, disease site, where we see disease site, where we see tissue destruction, then that's the disease site. How can we see the tissue destruction? We can't see. Sometimes we can see, sometimes we can't. But by doing, X-ray and also doing probing, then we know that tissue has been lost. Therefore, it is a disease site. Now, is it active or inactive? That is something else. Now, active disease site it shows what? It shows that apical migration. This is apical migration of junctional epithelium is very important in periodontitis. Never forget. First of all, the junctional epithelium and then apical migration. So we come to this phrase again and again. Apical migration of what? Of junctional epithelium. So active disease site, you will notice continued apical migration of junctional epithelium. How do you notice? When you probe now and when you probe in the other session, which will be 2 months, 3 months from now, you will see that the pocket deepened. You know that apical migration of junctional epithelium happened. Therefore, there is disease site because you have bone loss and tissue loss. And since it is deepening, then it is active disease site. Now, inactive disease site is what? When you cannot show apical migration of junctional epithelium, then you know that that disease site. Why it is disease site? Because destruction happened on that site. How we know destruction happened? From the X-ray or from probing. We know that destruction happened, so that's the disease site. Now, if we see the same probing depth, for example, you have 5 millimeter probing depth on one area, and you have the same thing 5 millimeter after 3 months, 4 months, 5 months, and so forth, you know that it is inactive disease site. So first of all, why it is disease site? I am repeating again and again so that you remember. When you see a destruction of tissue, when you get the information that tissue has been destructed, then you know that that's the disease site. Then you need to determine whether it is active or inactive. You can't determine just in one session. You need to follow the patient. Then you determine, is it active disease site or inactive disease site? So this is disease site. Now, so as assessing disease site, I talked about that. Characteristics of periodontal pocket. Periodontal pocket characteristics is what? Is first of all, you should have what? Bleeding on probing. So it talks about that. So it says that when you measure periodontal pocket, you will see deepened pocket, but you don't know whether it is active or passive, or it's not active at the present time. And then it talks about hurricane and the effect you can see, but you can't say that it is still active or not. So this is about periodontal pocket. Then at the end, it concludes that most of periodontal pocket in a patient mouth, in the patient which has periodontitis, are inactive sites. According to what? According to the study they did. So how they know that it is inactive? Because they followed the patient and they saw the same pocketing, the same amount of bone loss. Then they conclude that most of disease site in a periodontitis case is what? Is inactive sites. So in other words, there are active sites, but it is not most. Some sites. Now, so pocket, okay, so it says that pocket is an indicator of the past destruction from periodontitis. When you measure, you see 5 millimeter. It indicates in the past something happens, and it is like that. Now, next one, theories of disease progression. So it comes to different theory. Now, I think in one lecture, I do have extensive things on disease progression. So basically, progression according to the old view. First of all, the disease progression is different from one site to the other site. It is different in different people. It's not the same. It goes forward, but not the same in each individual. And even in a same mouth, and even on the same tooth, the progression is not the same. It can be different. So this is very important to know. Now, then progression, according to the theory which was before 1980, they postulate that periodontal disease progress throughout the mouth in a slow and constant rate. So according to that theory, up to 1980, they thought that periodontal disease will progress slowly and constantly. So in other words, it has constant rate. Then, untreated gingivitis will lead to periodontitis. That was the concept they had at that time. Now they don't have this concept. According to that time, when they didn't do anything for gingivitis, finally it will go to periodontitis, which is not the case, according to the study they did. But I need to mention, the progression theories, different progression theories. Now, current research indicated that theory is not correct. Now, next theory. According to that theory, you will see it will continually go forward. Periodontitis will progress, will get worse and worse. Okay? And if it is gingivitis, will come to periodontitis. Now, according to the current view, periodontitis is characterized by period of activity and inactivity. Then tissue destruction can progress at a rate, a small rate throughout the mouth. Untreated gingivitis does not progress to periodontitis in each case. In the previous theory, it would progress to what? Periodontitis. But according to the new theory, no, which is not like that. Now, then susceptibility to periodontitis is different between different individuals. Right now they are considering also host factor. At that time they didn't consider. They said, okay, when the patient gets periodontitis, it will go forward and it will progress. But right now, that's not the way. According to intermittent disease progression theory, you will see something like that. In other words, you have what? A period which nothing is happening, then suddenly it will progress, periodontitis, then nothing happening, then suddenly progress, and goes like that. So in other words, it has period of inactivity and period of activity. But right now we do have, I think, 4 or 5 theory, which we will go over that in about 3 or 4 lectures from now. Now, the last part is about epidemiology of the disease of the periodontium. So up to now, we talked about different things regarding periodontal disease in general, but we didn't go in detail on periodontitis. We go on different periodontal disease and the location and so forth. Now, epidemiology. Epidemiology is the study of the health and disease. Now, they use total population and they go for risk factor to see what risk factor are involved in disease. So that's the subject of epidemiology. Risk factor is not, in other words, it will increase susceptibility of the patient, of the person to periodontal disease. Epidemiology is going after a risk factor to find risk factors and also the relation of risk factor to periodontal disease. Now, that's about, now example of risk factor are what? In other words, risk factor doesn't initiate periodontal disease, but it contributes to progression of periodontal disease. So, risk factor, examples of what? Heredity, it is from gene, gender, male or female, and now physical environment, like smoking and so forth. Now systemic factors, like what? Different kind of disease, socio-economic status. These are risk factors for periodontal disease. And personal behavior. So personal behavior is what? Like hygiene, yeah. So these are risk factors. Now, so according to the epidemiology, large percentage of adult population has periodontal disease. Now, it talks about the current information about the method and behavior successful in what? Epidemiology. Goes after these things to see how we should go and successfully treat patient or prevent periodontal disease. So that's why they go after risk factor to find risk factors so that if we can control it, we can what? Prevent or we can help treating periodontal disease, both of them. So in other words, epidemiology is important from clinical point of view because of that. Now this one is self-explanatory. So the question which epidemiologist is asking are these question, you can read it, which is question all around, and they are going after these questions. Okay? So in other words, they go for the cause of the disease, and they go for genetic characteristic and other risk factors, different risk factors. So that's epidemiology. Disease prevalence. Now, disease prevalence, and then we do have disease incidence. Prevalence is what? Is in a population, the number of the case which has, for example, periodontitis, from present and past. That will be what? Disease prevalence. Now, the incidence is what? Disease incidence is the number of new cases which get that condition, which in this case is periodontal disease. So that's the difference between prevalence and incidence. Now, now here they go over prevalence and incidence, but basically it is like that. And we know that they use indices to get to the conclusion that in a population, what happened, the incidence of periodontal disease or something, and about indices. So they use example of indices that we use in periodontal disease are these things, which you see here. CPITN, EIBI, and the name is over there. Gingival bleeding index, gingival index, the screening and recording, and so forth. And each one. Now, variable associated with the prevalence of disease. So prevalence was what? The number of the condition from past and present. That's it. Now, so these are what? Variable. One is gender. According to the study, they found that male have higher incidence. In other words, new cases of periodontal disease, will see more male than female. Now, educational level, when the education is lower, the incidence is more. Socioeconomic status, again, you see greater incidence when the status is lower. In other words, in underdeveloped countries, you will see more incidence of periodontal disease. So that's socio-economic status. Now, age. Age, we know that the severity increases with age. Now, is a risk factor, but we know that as the person gets age, there are other things which comes into play, which when was young, it was not there. So you can't say that the age is, that's because of the age, this person has got this situation. Other things it comes, like diabetes and other high blood pressure and so forth. It will come with age. You know that. So then another factor, in other words, which called associated with prevalence of the disease is access to dental care, which can be because of the cost of dental care or because it is, for example, it is in a rural, yes?
Do you mean, you don't know you had on another slide, it said physical environment?
Say that again.
On another slide, you had physical environment. Is that the same as access to dental care?
Okay, physical environment, I don't have it here. So, in other words, you say that physical environment is dental care, yeah?
Well, you had, is this the variables associated with prevalence of disease, are they the same as risk factors?
Okay, so in other words, you want to know variable associated, no, it is the same thing. In other words, it is risk factor. Now, these are risk factors. So in other words, variable is equals to risk factor.
Okay, so on your risk factors page slide, you have also physical environment.
So let me see, I might have, again on the next page, let me see what, access to dental care, no. Yeah, it was physical environment, yeah.
Yes, is that the same as access to dental care?
Physical environment, it will be physical, it can be.
Okay.
Yeah, it can be. Very good. Pay attention to these details. So access to dental care now, it talks about more about access to dental care, about transportation, finance, and so forth, which is self-explanatory. Now, tobacco use. Okay, physical environment you can use this is as a habit. Now, habit, you can categorize it under physical environment or not. Like tobacco use, like smoking. Or you categorize under what? Let me see what the book categorized. And now, so this is the behavioral risk factor. Okay? So in other words, variable one is what? Tobacco, which is a risk factor. In other words, according to the study, they saw that irrespective of what kind of tobacco, either it is smokeless or smoking tobacco or hookah or whatever, it caused more severe damage to the periodontium. According to the study they did. So that's a risk factor. Okay? Now, then we have another subject, which is difficulties in measurement of periodontal disease. Why it is difficult in comparison to what? In measuring caries, it is difficult because we do have different variables. And we need to consider these variables in order to come to a conclusion. So it is more difficult. So basically it's like that. Now, also in caries we are dealing just with tooth, which is hard structure. But here we are dealing with hard tissue and soft tissue. So you see that there are multiple variables here. And again, for soft tissue, we do have tissue color, tissue texture, degree of bleeding, and you name it, probing depth, and so forth. For those reasons, the periodontal disease assessment is is not easy. It's difficult. From what? From epidemiological standpoint. They need to consider all these things. Now, from clinical standpoint, again, they talked about prevalence of periodontal disease, which in adults, in United States, they said that 47% of the adults have periodontitis. Now, at that time, they used the term mild, severe disease, but you know that right according to 2017 classification, we don't use mild or moderate or severe periodontitis, chronic periodontitis. We use staging and grading. So stage 2, stage 3, stage 4. But according to that, it's like that. Now, then we know that most of the tooth loss in adult population is because of periodontal disease. Again, according to what? According to the study. Now, then different indices, I put it over here so that you know according to what criteria they use. According to this index, which is called the Community and Periodontal Index of Treatment Needs. Abbreviation is CPITN, which is from Federation Dentary International, by Ainamo and the group which he worked with them. Ainamo is a periodontist. So now it measures what? It measures probing depth. This is what? This is index which they use for a large population. So probing depth, bleeding. Then they may use for measuring. Yeah. So they use these two things: probing depth and bleeding. So according to that, that's one. Now next one is what? EIBI, which is Eastman Interdental Bleeding Index. You can see basically they use what? Inflammation basically. Now pocket depth, it is difficult. On a big scale. Some of them they are not using. And if they are going for gingivitis, then they don't need to do that. So some of them they use. Also bleeding on probing they use. The bleeding on probing when they do flossing, they use in one of those is like that. Or if you use interdental, what they call, just toothpick into interdental area, and it bleeds, then they score it. So these are on large scale. This is epidemiologic study. It is not clinical. They have lots of people and they need to come to conclusion. So they use these indexes. Basically, it's like that. And there is a different one. Now, next one, gingival bleeding index. which these two person has. Again, gingival inflammation, bleeding from interproximal sulcus within 10 seconds of flossing. So in other words, they floss, within 10 seconds they go back, bleeding, they put the number, and they use it as a guide for determining periodontal disease, which in this case will be what? Which should be gingivitis. Now, next one, again, it is gingival index by Low and Silnes. This one was used more, severity of gingivitis based on color. This is used more criteria, color, consistency, and bleeding on probing. So this is GI, or gingival index. These are all used in epidemiological study, in different studies. Now, next one is modified gingival index, which is what? Gingival, so it's almost the same, but assess severity of gingivitis without probing. Okay, so without probing, does not use probing. So it is modified gingival index. Now, periodontal index by Russell, severity of gingival inflammation, again without probing. So basically they do Ramford periodontal disease index. That was periodontal index. This is periodontal disease index by Ramford. Severity of gingival inflammation, pocket depth, level, in here, level of gingival attachment. Also they consider it. So they use more criteria in Ramford. So basically, I am done. So if you have any question, let me know. If you don't have any question and you have time, I will ask question. So how about that? Or you choose not to ask question, or I also ask. Yes, go ahead.
The charts that you just showed us at the end are. Do we need to memorize the?
No, remember. I try not, because this is four. In the exam it is four choice, and you see that I use four choice. It is not just 5 or 3 or so. So it is multiple choice. It is 4 choices. Now I try to use something which you don't need to memorize. In other words, going back to the question, either you will see on the topic something which describes so that you remember where you need to go back there, or different answer when you compare, you come to a conclusion, okay, this will be the right one. In other words, I am trying so that you use, your common sense, and not to memorize. Something you need to know, the important thing, which I am emphasizing. I'm going back again and again. Those are very important, you need to know.
Okay.
Now, something like in here, indices, it is very difficult to remember which one.
Okay.
And I'm not, and it is also, it is on a large scale. It is not what you use every day.
Okay.
But I might ask a question about indices which pertains to your work in the clinic, or can help you in the clinic.
Okay.
Now you got my point?
Yes.
Good. Yeah, I may ask question, because this should be clear so that you know how to go about that. So in other words, memorization is not my intention.
Okay.
I want you to think, even if you don't see what's going on, to check different answer and choose the best one.
Thank you.
Okay? My pleasure. So, in other words, it is important that you get the material in the class right now. Then you have no problem. You go after that, you check it. Right now you have 10 minutes. You can over that. You don't go over that. I will go over that because this is very important. And then you can refresh yourself. and never put it in the last moment and let me go and read what's going on. That's not good. And especially for you, because you need to be fresh every time you are in clinic. Okay? So basically what I talked about today, it was about an overview of periodontal disease. Now, did I talk about periodontitis? Did I talk about periodontitis extensively? No, I didn't. I just mentioned that periodontitis is a form of periodontal disease. Periodontal disease is can be gingivitis or periodontitis. This is very important, okay? And you should know that. That's why, because I'm going back. Now, also we talked about pocketing, different kind of pocket, about defect, different type of defect. Oh, and in defect, one of you, paid attention to that. According to, go to the, especially to the pictures. Or if you see picture, read it and see the picture. Because you will remember, and then you will have no problem remembering that. So never omit picture. Actually, go to the picture first, see the picture, you get an idea what's going on in the book, and then you start.
How many of you have purchased the book, or are you guys using it? Are you looking at it?
Not yet.
Yeah, come on. Yeah, I think it'll be very helpful when you take your exams. It's very good. Because a lot of his material that he's given you is straight from your textbook.
Actually, all the material is from the
Questions
textbook.
questions from the
I'm trying not to get out of
could be
textbook.
on your midterm and your final as well.
That's why I think he wants to read it. So we understand.
Okay,
Right now, trying to get out.
yeah, let me see.
Should be a button at the top there. There you go. Go ahead and click it again.
Is it on example 5?
Well, you might be able to just
There you go.
Hey, don't forget to download your quiz on
Okay, now how can you disconnect it? He says it's over here.
I'll drop it here. So go ahead and disconnect it. Or here, unplug these, yeah. Do you guys have a class right after? Okay.
So this is like that, and this one. Okay, thank you, Debbie. This is yours, and this is mine.
I will turn off the projector just so we,
Let me talk.
just for right now, then we can turn it back on.
Okay, so
Okay, you got everything? You're good.
let me get out. I need to do it.
Oh,
This one.
okay.
Yeah, thank you, Debbie.
You're welcome. Got to take this off, turn this off.
Oh, no. I almost forgot.
You don't want to be talking to everybody.
Yeah. Thank you. And off. Off.
I turned it off.
Thank you. Oh,
So next week is the class. It's going to be half hour short.
yeah, half hour. Actually, next week I have more material.
Uh-oh.
But I need to manage it. And I will condense at the end.
I like
Yes. Okay, of course.
See, if I could get into like a portable program.
You finished a little early today.
Yeah, I wonder why.
Well, maybe because you were planning to be half hour short. Maybe that's why.
Yeah, but then I can't bring my
Usually it takes more time.
Yeah.
Dude, I
For
don't
next
honestly
week, I
thought,
need to
I
see
don't
what
understand how
working.
go to West Texas.